Presenting to us today, the ATIPAN, a community-based digital health strategy for universal healthcare. Let us all welcome Dr. Romulo Joseph F. De Castro, DOST Balik Scientist from the University of San Agustin.
Thank you so much. Sige, no, it looks like everybody left, so I'm not gonna acknowledge anyone. Except maybe the local luminaries. Thank you for having us here. And the LGU representatives. I think my presentation is more directed to you anyway, so it's okay. And let me just say that some of my work, I have very little, sige, nag-alisa na yung mga DOST people, no? So let me just say that my work has not been funded by the DOST. It's more even, maybe more appropriate that, well, even the DOH actually, most of our work has been funded internationally. But, you know, they're really localized, and the reason they're funding us is because they would like to support us and help us with the work of science and health here in the Philippines. All right, so I'm talking about ATIPAN, which is our community-based digital health strategy for universal healthcare. And let me just say, let's see, ayaw. Okay, so maybe I'll just ask you to, you know, move the slide. Now, can you move the slide, please? Yeah. So let me just say the bottom line. The bottom line is, with ATIPAN, we were able to show that UHC can be attained. So very easily, to be honest. And, you know, we always say that, you know, UHC will take us forever to reach and take us many, many years. But in fact, in ATIPAN, and I'll show you, it was a very short time that we were able to provide digital health to the farthest communities in the Philippines. Okay na. So, and we published about it. So there is a blueprint. And for the LGUs who may be lacking in healthcare services for their citizens, or maybe hindi makarecruit na mga doctors to their communities because most doctors want to live in Manila and do their practice in Manila, we can now provide the services of these doctors remotely through digital health, through telemedicine. No? So it's no longer impossible to reach the most remote areas in the Philippines and provide easily accessible healthcare. And we showed that and we published about it. All right. So next, oops, sorry. Next slide. Ayan. And so this is where we are all over the West Region 6, Western Visayas. We have telehealth operations in all of the provinces of Western Visayas, including Negros Occidental, which is now NIR. And in Iloilo in particular, we have a lot of communities. 1 community in Capiz, 2 in Aklan, 3 in Antique, and 1 in Guimaras, and 1 in Negros Occidental. So all over the place, sometimes in the mountains, sometimes by islands, and they're just very remote. But now they have easily accessible digital health. All right. So ATIPAN, which means to take care of in the Hiligaynon language, is a digital health implementation success. It took us only 6 months to set it up. And that's because we already have the substrate now. We've been working with the communities for a while. We have informatics operations, and we've developed a lot of digital tools already. All we needed to do was to roll them out and do the social preparations of the communities that will benefit from digital health. The initial uptake of telehealth was extremely high, and this is during the pandemic. We even beat out the US in the uptake of telehealth. So in this way, we actually have leapfrogged developed countries in telemedicine. ATIPAN is a digitally enabled, community-navigated, and that's very important because the community leads. The marginalized communities lead in being able to access healthcare. It's a health service that's operational in difficult settings, in remote, underserved, marginalized, and highly vulnerable indigenous and rural low-income communities of migrants, displaced people, and displaced people communities. So you can imagine, we've done this in the most hard settings. So what's preventing us from actually moving it forward to the rest of the country? So, okay, yun na actually hindi ko rin alam. But I think maybe our NEDA can like give us some pathways towards moving forward with digital health all over the country, because this is the way we can provide universal health care. And the telehealth data, which is what we gather from doing telehealth consultations all over those 15 communities, is not just a byproduct of the implementation, but a healthcare resource for the communities and our healthcare system. So this is how it looks like. So just like some quick data visualizations. From the ATIPAN program, we've been able to identify the top 15 diagnoses, and you can see mostly upper respiratory tract infection, there's UTI. Malnutrition is big in these communities because they're marginalized, they're underserved. You also see TB. So number 12 is pulmonary TB, which is 2 to 3 times higher in these communities than the national average. And why? It's because there are no healthcare systems operational in these communities. And now ATIPAN is seeing their data for the first time. And but you can also see that there are diagnoses of well child and well adolescent. No, that means that the communities are now seeking healthcare. These are evidence of health-seeking behaviors. All right. Oops, sorry. We also see that in terms of age distribution and sex distribution, there are more women and girls utilizing telehealth than men and boys. There's a reason for that. It's because the men go out to work and the women are left, and they have more time to do telehealth, and they bring the entire families with them. So this is a good thing. All right. Our principles in operation are prioritization of the most marginalized, and we're very deliberate in this because we know that if we attain success in these communities where there's nothing, then we can translate it all over the Philippines, and we have attained success in these communities. I won't mention the inverse equity hypothesis, but that's essentially saying that the technologies that we need to develop have to be developed for the marginalized communities in prioritization. So, sila muna bago yung mga may kaya na. Yun munang mga walang kakayahan. Doon naman talaga nag-uumpisa yung ating development if we address the most marginalized communities na walang access. So, bigyan natin sila ng access and everything will follow after that. This is a community-centered, participatory leadership building. It opens spaces for the disempowered. It promotes well-being, learning, and unlearning. We learned a lot. We unlearned a lot in implementing ATIPAN. I won't go into the details, but you can read it in our paper. Our approach is also decolonized, meaning we give agency to these marginalized communities. In the end, it's up to them to utilize telehealth. They have their own herbal medicine. They have their own cultural practices. Telehealth that we provide is only an addendum. It's something that they can use. They may not use it. It doesn't matter, as long as it's there. And it's non-extractive, meaning we have the data, but we're not going to do anything with the data without permission from these communities. So these are our values. And I think these are the ones that make it really, worthwhile, and it facilitates acceptance of digital health technologies in the most marginalized communities. Oops, sorry. Mali yung napipindot ko. Anyway, I'll skip this. And ATIPAN has been able to input to ASEAN. So, in fact, ASEAN has mentioned that the ATIPAN Telehealth Project improved healthcare access to the underserved, and it becomes a model for ASEAN, which is tragic because it should be a model for the Philippines or across the Philippines. And yet the ASEAN countries are adopting what we have because we haven't had any chance to actually input to our own development folks planning our development. And even if we do, and we did, they're not necessarily well received. So it's tragic, but that's what's happening. We ASEAN countries actually accept all of the findings and the learnings that we have in ASEAN, but the Philippines doesn't yet. And we're also able to input to the World Health Organization. So again, it's a glaring example of things that we can do it. We have the expertise, but our country doesn't necessarily want to adopt all of these things that we've already shown. All right, so our implementation is values-driven, in particular the value of fairness, meaning, we really prioritize the most marginalized, okay? We have, our configuration involves technology. So you can see that the data is centralized in an electronic medical record that we actually developed ourselves. So data from those 15 communities all over Western Visayas is centralized, and so we can visualize the data very easily. No? So, and it's the technology that connects the communities to the doctors that are far away in the cities. All right, so ATIPAN has won multiple awards internationally. It was actually a prize winner for the e-health observatory in France. And also, the Mental Health Commission of Canada has recognized ATIPAN as one of the 8 great ideas changing lives worldwide. So we're recognized internationally. Okay, in the Philippines, we do have one award. Our telehealth coordinator, Pia, got the Outstanding Community Service and Public Health Award. And again, one of our telehealth doctors also received an international prize doing research on the patients that we have in ATIPAN. So again, a lot of international recognition, but very few national recognition, which is, again, to me, it doesn't say much about, the Philippines as a country when our own expertise is not accepted here. Anyway, but forget all of those awards. What's more important are actually what the communities are saying. And what the communities are saying is that, ATIPAN actually helps, saves them effort, time, and money. They do not experience prejudice anymore because they usually do when they go to our public healthcare system. It helps unite their communities and to clear misunderstandings. And they want more coverage, more patients to be helped by ATIPAN, and that for ATIPAN to last longer. And, sorry. Yan. So these are just like a collection of things that they've said. ATIPAN project serves as an avenue for us to be heard. And these are the indigenous patients, community coordinators now. And they feel empowered with ATIPAN. And ATIPAN, gives them confidence in working with non-indigenous people. So, and this is probably my second to the last slide. We conducted the economic modeling for ATIPAN. How much does telehealth cost? So this is our question. It's expensive because you bring telemedicine and digital health to remote areas. That really will cost money. And our estimate is that each telehealth consultation actually costs around 3,600 pesos per telehealth consultations at 3,000 patients a year. So I think after 4 years, we have about 10,000 patients in ATIPAN already across the region. However, when we modeled the cost, when you scale it, the cost actually decreases. So you can see here, when this is the initial cost at around 3,500, but as you increase the number of patients or as you scale ATIPAN, the cost will go down to below 1,000 per telehealth consultation. So pwede, kayang-kaya. Just like, if we were to dedicate all of the billions that were lost in the flood control projects, we will cover the entire Philippines now with telehealth care over and over. Kayang-kaya. So it's not that expensive. And even the infrastructure is not that, not that hard. We did it in Western Visayas, so there's no reason we cannot do it anywhere else. Well, maybe in BARM, it may be harder. Kasi mas underserved ang BARM, no? But, we can do it. Kayang-kaya. Sige. All right. So, let's see. So, the future is mental health, pandemic epidemic surveillance, indigenous health equity, continuity of care, women's and reproductive health, and also climate change, the link between climate and health. And, okay, let me press more. Oops, yan. And, well, I'll just keep going. So we also are working towards telemental health, which is telepsychiatry, e-dementia care. Now, this one was funded by DOST, our work on e-dementia care. And then using voice to diagnose mental illness with AI. All right. And this is a health map. This is a map of all the healthcare facilities across the region, which we are now moving forward with and validating all of those healthcare facilities. Whether or not totoong merong services doon. Because sometimes the DOST release these data, but in fact, there's really no healthcare facility there. Or there is a facility, but there's no doctor, there's no medicine. So, these things need to be validated. Lastly, so I have to thank you for listening to me over 10 minutes. But let me just make a quick plug. So, First, tonight, there's a UN session, UN General Assembly Science Summit session where ATIPAN is actually participating, and Professor John Petrola, who is professor in San Agustin, will talk about ATIPAN and the AI that we are doing in ATIPAN. And tomorrow, I'm convening a session at the UNGA Science Summit and involving a lot of leaders in TB, data, digital health, and AI from across the Asia-Pacific region. If you can attend, so I guess maybe you can take a picture if you like, and that's the link where you can register. And let me see. So this is the other one. There, I provided the link where you can register. So that's tonight at 7 p.m. and tomorrow night at 9 p.m. Thank you, everyone.